Good afternoon, good evening, good morning, wherever you are. Welcome to the first webinar of the third series of EPOS webinars. I am Hakan Ömeroğlu from Ankara, Turkey, and I am the Vice President of EPOS. I'm gonna moderate this webinar entitled Current Standards in DDH Screening with my dear friend and colleague Renata Pospisil from Vienna, Austria. She is one of the immediate past councillors of the EPOS Executive Committee. Now we have a very interesting topics and a distinguished faculty in this webinar. First, Renata is gonna talk about the current standards, techniques, and protocols in the graph method. Then Maurizio De Pellegrin from Milan, Italy is gonna talk about the best timing for newborn hip screening. This talk will be followed by two interesting talks about the management of graph type 2A hips by Blazej Prujinski from Lodz, Poland. He is the young councillor of the EPOS Executive Committee, and Bettina Westo from Düsseldorf, Germany. And I'm gonna talk about the nationwide newborn hip screening experience in Turkey. And finally, Renata is gonna answer the question, which type of newborn hip screening is the best. We are gonna have enough time for discussion, and you may ask your questions to the panelists by using the question function found in the control panel. We thank all the faculty for kindly accepting to attend this webinar and to share their valuable knowledge with all of us. We also thank all the attendees who has registered to this EPOS educational activity and the EPOS central office staff, especially Sunny Hilton, who has made this live educational activity possible. Last but not least, we thank Orthopediatrics for kindly and seriously supporting this educational activity of EPOS. Now it's time for me to give the microphone and screen to Renata to make his talk.
Dear colleagues, from me also a warm welcome to our DDH screening webinars. And I would like to start with a short repetition of Graf's hip sonography so that we all know what we are talking about the next hour. The problems of visualizing anossified parts in a newborn hip and at the same moment to show movements of the femoral head was solved by the development of hip sonography. And I must admit that this slide is a little bit overcrowded, but I would like to focus on the fact that despite the fact that Graf introduced hip sonography in the late 70s and started to do hip sonograms in the 80s, the technique was finalized in the early 90s with all its recommendations to the treatment, to the evaluation of 2A immature hips and so on. And since then, the state of the art is to learn hip sonography according to Graf by an instructional course as a standard and not to teach it by bedside teaching. You need to know that there are main pillars of Graf's hip sonography, starting with the correct scanning technique, using a cradle and a probe guiding system. And then once you have frozen your ultrasound image, you should start going through the so-called checklist number 1, which is a correct identification of 8 anatomical points or markers in your hip sonography. The first one is the identification of the chondro-osseous junction. The second one is the femoral head with its visible or not visible ossific nucleus. The third one is the synovial fold ending into the joint capsule. And the next and fifth and very important anatomical marker in the hip sonogram is the so-called labrum, a hyaline structure which is triangular, shown with an echo within the hip joint and its base ending on the cartilage roof of the baby hip joint, which lies just above the femoral head and below the bony roof of the baby hip joint. At the end, you should identify the bony rim, which is the most lateral point of the concavity of the bony socket, or the turning point from concavity to convexity. You are obliged to identify the bony rib for the further than description or measurement of the baby hip sonogram. Once you have correctly identified those 8 anatomical structures, you're allowed to go on to checklist number 2, which is checking the landmarks. You may follow this checklist in order to be able to identify the standard plane in which you should freeze your hip sonogram while you're doing the examination. And for identifying the correct standard plane, which is in the mid portion of the baby hip, you need to be able to identify 3 coordinates or landmarks, which are first the lower limb of the bony ilium, secondly the midsection of the bony roof, which is an echo just parallel to your left or right border of your ultrasound image scan, and at the end the labrum. In order to be able to see what problems can arise with turned probe and with not being in the correct standard plane, you should look at the 3 ultrasound images here on my slide. If you turn the probe, as seen in number 1, too much anteriorly, your echo of the os ilium will narrow the left border of your ultrasound image, and you might have a false positive diagnosis. Your hip might look too bad. If you turn your probe too posteriorly and then identifying the good coverage of the baby hip, you might have a posterior scan with the echo of the os ilium looking like a nose and maybe having a false negative diagnosis. That's why it's very important for you always to be in the middle part of the baby hip joint and to be able to say, okay, that's my standard plane. After checking checklist number 1 and checklist number 2, follow the description. The description helps you to limit false diagnosis through measurement only, and you should start to describe the bony roof, which could be good, deficient, or poor. Type 1 hips, normal hips, always have a good bony roof. Type 2 hips, either physiological, immature, or deficient, may have a deficient bony roof. And poor bony roofs have type 3 and type 4 dislocated hips. Then go on with the description of the bony rim area, which could be angular or blunt, rounded, and flattened. Type 1 hips, normal hips, always have an angular or a blunt bony rim area. Type 2 hips always have rounded bony rim areas, and decentered, dislocated, type 3 or type 4 hips always have flattened bony rim areas. At the end, you should be able to describe the cartilaginous roof, which can cover the femoral head or can be pressed upwards or downwards. In type 1 normal hips, the cartilaginous roof is always lying above the femoral head and covering the femoral head. In type 2 hips, the cartilaginous roof is still covering the femoral head. And in decentered, dislocated hips, the cartilaginous roof is pressed upwards, like in type 3 hips, or pressed downwards, like in type 4 hips. At the end, when finishing the anatomical description, you're allowed to do the measurements. With the measurements, you can be able to measure the so-called alpha angle, which is included by the baseline and the bony roof line. You need the alpha angle to be able to differentiate between the different types of grafts, hips. And the next angle you should measure is the beta angle, which is included by the baseline again and the cartilage roof line. The beta angle differentiates between 1A or 1B hips and 2C, stable or unstable, and D hips. If you, at that moment, you don't know by heart the different angles and different types. You can classify the baby hip using the sonometer, where you can easily find the angles and the types behind these angles. So in conclusion, Graf's technique should only be instructed by standardized courses instead of bedside teaching, by teaching to do checklists each after each other in order to minimize errors and false diagnoses. Thank you.
Good afternoon to all. Let me start with this paper from Susan Mahan, published 2009, about the question to screen or not to screen, and she concluded that the best strategy is a selective ultrasound screening. 6 years later, and the paper titled, "What has changed in the last 20 years?" The authors say early diagnosis and treatment is critical to provide the best possible functional outcome. We perform a literal review of the last 3 years, putting the keywords DDH and early diagnosis, DDH and ultrasound, DDH and treatment. I want to talk in this presentation all about early diagnosis. We collected 14 papers. I want to show you briefly some summary. So from Australia, they performed a selective ultrasound screening, and they concluded that they have a high rates of late diagnosis. And from China, they concluded that early diagnosis or early treatment might be the key point in the DDH treatment. And from UK, they performed a GP check at 6-8 weeks. And they found that 4 out of 5 children with DDH were not identified by clinical check. And from Sweden, they lowered the age performing clinical screening at 6 weeks, 6 months, and 10 months. They lowered the age after diagnosing a half of all children, but another half had still late presenting hip dislocation. And very interesting paper from the States, they say there is a need for ultrasound enhanced examination training for the diagnosis to improve the early diagnosis of DDH for orthopedic surgeons and pediatric residents too. And this is also very interesting from the States. Also, expert examiners miss a significant number of frankly dislocated hip. It may explain the persistent rate of late presenting DDH. Let me summarize the literature to a review of the last 3 years. The rate of late diagnosis increasing performing selective ultrasound screening. Risk factor for failure are older age. The effectiveness of clinical examination is very low, and there is a need of ultrasound enhanced examination training. And what about early diagnosis in PubMed? We performed this literature review of 10 years, and the median age of 19 articles about the topic was 3 months. If we put the keywords risk factor, it decreases to 6 weeks. And another interesting paper from the state, the majority of patients cited by this author with symptomatic osteoarthritis of the hip did not match selective ultrasound screening guidelines. So to answer to this question, we performed a study to look at the development of the acetabulum. We could collect 93 type 3 hips according to Graf. That means a severe dysplasia with dislocation of the femoral head. And we perform an ultrasound diagnosis and treatment start, and a second follow-up, and a third follow-up. And so the first result of the anchor eigenvalues was that, of course, at the second follow-up, the third ultrasound, we have an improvement of the alpha angle value. But if we divide the patient in three groups, the group 1 with diagnosis and treatment below 11 days, and group 2 between 11 and 42 days, and group 3 more than 42 days of life, we have different results. And you can see in the group 1, the alpha angle achieved the normal value of the control group, and in group 3, not at all, with a significant, statistically significant p-value. Again, the comparison between the three groups, we have no significant result in the comparison between group 1 and the control group. That means we have normal HEPs. And again, the alpha angle gain at the time of the diagnosis clearly represented by this diagram, in which the best result, the best alpha angle gain we have in the first week of life. And in other words, we could achieve mature HEPs in almost 90% of the HEPs in the group 1 and only 50% in group 3. And another statement is that longer treatment does not mean better results. After 3 months, there is few further improvement. As you can see, this mathematical derived curve, in the first 6 weeks, we have a fast development of the tablet. In the second or in the following weeks, we have a slow maturation of the acetabulum. And this study, in my opinion, a very important study, shows a strong dependency between alpha angle gain and the time of diagnosis. The younger, the faster. And the mathematically derived maturation curve exponential in the first 6 weeks of life. Fast maturation in the first 6 of life is very important. No significant correlation between alpha angle gain and length of treatment. So to answer the question, best timing for HEP sonography in newborns, as soon as possible, before 6 weeks of life. And there's also an interdisciplinary consensus and an inter-society consensus published with those statements. And I want to stimulate the most interested colleagues to join us in the ICOT Society. We have some meetings. This is a society about the DDH evaluation. We published recently a book about early sonography diagnosis, from the diagnosis to an effective treatment. And I think a pediatric orthopedic surgeon should have a US transducer around the neck as the anesthesiologist has a stethoscope. Thank you.
Hello, everyone. I'm really happy to be here. I'm really honored to, I would like to thank EPOS to have the possibility to participate in this meeting, to this course. I get a quite difficult topic to talk about the type 2A. Is it like immaturity, or is it early onset of the hip dysplasia? So what means type 2A? Is it a physiologically immature hip joint, or is it a true hip dysplasia? So what we know, so what was first already mentioned here, that type 2 hip joint is also a centroid hip joint. The total roof, bone plus cartilage, is well covered the femoral head. The proportion between the bone and cartilage differ from the type 1, with the more cartilage and less bone which cover the femoral head. And the bony rim is also rounded in comparison to cartilage roof, which appears in the type 1 hips. This is what we know from graph study, which I mentioned below. Renata mentioned about the type of the bony roof, so I would like not to repeat the same thing, but usually this bony roof, it's a little bit, it may be adequate or with some delayed ossification. The bony rim may be blunt, or sometimes it may be like rounded, but usually it's more blunt. This is more typical for type 2 hip joint. So when Graf was studying, when he was trying to establish his technique, he saw that some of type 2A hips go to the good direction of treatment and to the good direction without any problems and mature itself, but not all of them. So he was trying to find what's going on, what is the difference between in the group of type 2A hip joint. So he found that at the birth, the minimum maturity of alpha angle should be 50 degrees. Then the hip joint is changing, is growing, and the alpha angle becomes 60 degrees at the end of the 3rd month. But some of these hips had some delayed maturation and didn't follow this linear maturity level and differ from this type. So he called the normal maturation pattern as like type 2A plus hip, and other hip joint which cannot follow this linear maturity as type 2A minus. He presented it very well at the sonometer, which probably all of you know very well. So of course, when the checklist 1 is validated and you pass through the checklist 2 and you analyze all this landmark, then you can draw the line. And here what you can see on the sonometer, that when you look at the type 2A hips, that some of them have here the number from 55 degrees up to 60 degrees, depends of the month. So this helps you to find where is the hip joint when you diagnose it at, for example, 6 weeks of age, 7, 10 weeks of age, etc. So when they follow this linear progress, you may be sure that you have type 2A plus hips. Let me show some examples, like here. This is the moment which I would love to have this Kahoot tool and make you voting. What will you do at different age? So let's put to the situation as the doctor diagnosing this hip. You may have this type 2A hip at 2 weeks old with the alpha angle 52 degrees, like you see here at the left slide. So then for you, you know that it's type 2A hip, but you cannot tell if it's really a hip dysplasia or this is like an immature hip. What you know that you need to follow that. At 7 weeks old, you already know that you are passing through the threshold of the type 2A plus or type 2A minus. And with the knowledge which we already gave you, you know how to classify this hip. And also the same thing is coming at 11 weeks old, that you know that this hip won't achieve 60 degrees of alpha angle in 1 week, like at 3 months. So these cases are rare, but I have found for you some examples, like for example here, it's another kid with the type 2A hip joint, and also depends on the age, you should classify them. For sure at 2 weeks old, you will wait and observe, but probably later you will think what to do with this hip with the alpha angle 51 degrees at 6 weeks old, or especially better at 11 weeks old. There's another case found in our outpatient clinic with this alpha angle type 2A, and we jump in the same problem of the discussion, the decision what to do at 7 weeks old. Should we wait or should we treat them? But this will be a part of another talks during today's webinar. all these hip joints, which I show you here, like immature hips with the type 2A, went well diagnosed and well followed like it should be with the rule. So all the type 2A minus were treated and gain maturity a little bit later, but still without any other intervention. So like a take-home message, type 2A hip may be the early onset of the dysplasia, and of course request some follow-up, especially when they didn't follow the maturation pattern of the 55 angle at 6 weeks, at 60 degrees of alpha angle at 12 weeks old. Unfortunately, it is not possible to differentiate between type 2A plus and type 2A minus hip joint before the 6 weeks of life. Thank you for your attention.
Professor Westhoff, we can see your presentation.
Oh, I don't see it. Is it fine now? So, hello to everybody, also from my side. So we also heard a bit about the type 2A hip. And you know, the question is now to treat or not to treat. So you all know there is, in the graft classification system, you have the stable and the unstable hips. And in the type 2, it's something confusing because it's a bit of everything. But a 2A hip is a stable hip, which is defined with an alpha angle of 50 to 59 degrees in babies at the age of younger than 12 weeks. And at the age of 6 weeks, we have to discriminate and distinguish the physiologically immature ones and the real pathological dysplastic ones. So the prevalence depends on the age of the population examined. And in most of the studies, it's between 10 and 15%. According to Graf, we do not have to treat the hips which are physiologically immature, but we do have to treat the real pathological ones with an adduction brace. But this algorithm is not generally accepted. One point is that a lot of hips will develop physiologically and become normal, and then treatment is overtreatment. And the second thing is that the ultrasound technique itself is of questionable reliability. And indeed, in a systematic review, there's a poor to moderate inter-examination inter-rater reliability. And the sad thing is that in the last 3 decades, it even declined. So this should stimulate us to improve the examination quality by continuous education, attendance of instructional courses, and very strict application of the Graf standards, like using a positional device, the checklist, and so on. So to treat or not to treat, so we have to know something about the natural history. And there we have the study of Hakan. They screened the babies at the age of 3 to 4 weeks. And then at that age, they found 13% type 2A hips. 3 weeks later, almost 80% turned to type 1, but 12% required treatment because they were now pathologically dysplastic, especially in girls. And interesting, only 14% of the treated babies had a risk factor for DDH. And there's another study. It's from the Netherlands, and they did the first ultrasound examination with 1 month, range 2 to 7 weeks, then another one with 2 and 3 months. At the first ultrasound, 36% of the infants showed an immature hips and 1.5% a 2A minus hip. If you now follow the development of the physiologically immature hips, most of them, 95%, were normal at the age of 3 months. But with the type 2A minus hips, this was only 85%. In other words, 15%, almost 15% were pathologic at the age of 3 months. And if we add the almost 5% of the primarily physiologically type 2A plus, which didn't develop nicely, so at the age of 3 months, we have a pathologic dysplastic hip in almost 20%. In a literature review by Sackers, they found for the graft 2A hips, depending on the age of the examination and the follow-up time, also a normalization rate of 80 to 95%. This means that 5 to 20% will not develop normally, and he also found a deterioration rate of 5%. They concluded that graft 2A hips can safely be followed for a longer time, but they didn't distinguish between the physiological and the pathological hips. So there is a significant amount of primarily immature physiological hips that turn to a pathologic hip. There are some clinical risk factors discussed, and also an angle gamma. The angle gamma is the angle between the baseline and the line from the border of the ilium to the medial corner of the labrum. And the cutoff value is 78 degrees. Hips with an angle, gamma angle of less than 77 degrees will not develop to a normal hip, but a dysplastic one. So, will adduction treatment help? There's one study by Wood, and he did a study on hips aged 2 to 6 weeks, and they either got a public harness or just observation, and they included stable hips during the Barlow maneuver during ultrasound examination, and hips had a femoral head coverage of less than 40%. At the age of 4 months and at 2 years follow-up, they didn't find any significant difference in the acetabular index. So no benefit from early splintage for stable but dysplastic hips. But again, they didn't classify according to graph, so we do not have any knowledge about the pathologic morphology of the acetabular roof. In another study by Kim, the children were a little bit older, also stable hips, with an alpha angle of 40 to 55 degrees and a femoral head coverage of less than 50%. Whether the hips were treated or not depended on the opinion of the pediatric orthopedic surgeon. And after 2 years, they couldn't find any significant difference between the acetabular index in these two groups. So they concluded milder, stable sonographic hip dysplasia can be observed. But this study has several limitations. First of all, they didn't use a positioning device for the ultrasound examination, which is mandatory to get a reliable outcome. Then the study cohort was quite inhomogeneous. So we had alpha angles of 40 degrees, so meaning highly dysplastic, unstable hips, and we had the ones with an alpha angle of 55 degrees, which is rather a mild dysplasia. And when analyzing the treatment results, they didn't consider the pathoanatomical situation of the hip. And by the way, they had a quite high dropout rate. So in the Netherlands, based on the currently available literature, they developed a treatment algorithm. And for the type 2A hips, they don't recommend treatment, but only ultrasound follow-up examinations. Again, no distinction between physiological and pathological hips. And this concept does not consider the histopathological damage to the chondro-osseous junction of the acetabular roof that might occur when there occur shear forces. And so early treatment would be much better in this sense. So treatment, over-treatment, actually the evidence is not very well. And there's no study evaluating especially the natural history of type 2A- versus treatment. And the analysis of the natural history shows that 81 to 88% will develop normally. And indeed, this means overtreatment. But on the other side, the remodeling potential is the highest within the first 2 or 3 months, as we know from the maturation curve. And delay of treatment means negative consequences for 12 to 19% of the infants, with a longer treatment time, an impact on the motor development, and probably a damage to the chondro-osseous junction. So why not treat just in case? Then you are on the safe side, have a short treatment time, in average 4 to 8 weeks. The child is ready in time for start of locomotion, and we do not have a significant complication rate. And I think the treatment costs and probably psychosocial problems for the caregivers are a minor problem. So should we treat the 2A hips? The physiologically immature hips only need ultrasound control. There's slow evidence about the natural history for type 2A- hips, and treating all the type minus hips means being on the safe side. And it's clear that we need further high-quality studies based on graft classification system. Thank you very much.
Okay, I'm gonna talk about the results of the nationwide newborn hip screening program in Turkey. Now, a short history of the program I would like to give to you. The incidence of DDH was estimated to be around 1 per 100 live births in 90s in Turkey. The prevalence of dislocation, subluxation in childhood was found to be around 6 per 1,000. And it was reported that about 1/3 of the total replacements was due to DDH in Turkey. Everything changed when a couple of Turkish surgeons visited Professor Graf in Stolza to learn hip ultrasonography in 1996. And he's saying, my residents do not like me because they see only a couple of DDH operations after nationwide hip screening program has been initiated, really impressed us. So it was time for us to do something in our country where DDH had been a serious health problem, as the number of new DDH cases was around 13 to 15,000 per year, and we were performing many osteotomies in neglected or missed cases over the age of 2 and 3 years. Therefore, local institutional newborn hip screening programs were immediately initiated in several parts of the country. So nationwide hip ultrasonography and DDH courses were organized. Professor Graf visited Turkey several times to personally teach the Graf method. Local training programs for family physicians and general practitioners about the importance of DDH was organized. And the preliminary results of our institutional universal screening program encouraged us because the rate of pelvic osteotomy was 0 among the babies who were immediately treated after general ultrasonographic hip screening within the first weeks of life. So we had to determine the type of hip screening, as the number of live births was around 1.2 million per year, and we had limited number of trained staff in hip ultrasonography. However, we had to initiate the newborn hip screening as soon as possible, and we initially decided to start with the selective program and then to convert it into universal one. The executive committee of the National Society completed the project, and this is the photo taken just before the presentation of the project to the Ministry of Health. Training of the trainers from all cities was performed in 2010, and these trainers trained the health staff related to the nationwide hip screening program in all parts of the country between 2011 and 2013. Finally, the official circular was published in July 2013. The main program partners are the Ministry of Health and Turkish Society of Children's Orthopedics, and the examination and treatment costs of newborns are covered by the Social Security system. And the results obtained from the data of the Social Security system between the years 2015 and 2020 after the initiation of the nationwide hip screening. In 2020, 94% of the newborns in the country was being screened, while it was about 50% in the beginning. And nowadays, it is almost 100% of the babies are being screened. You see the rate of screened newborns did even not decrease in the pandemic. So we now have an universal hip screening that has developed simultaneously and spontaneously. This spontaneous transition is due to the increased awareness of both parents and health professionals and increased number of training activities of health professionals. And perhaps the most important graphic, the rate of primary surgeries significantly changed. There was a 50% increase in the rate of closed open reduction, whereas 60% decrease in the rate of osteotomy. We do not have a detailed nationwide data about the change in the rate of abduction bracing, but it is all our observations that the rate of abduction bracing has significantly increased. We are now conducting a multicentric nationwide study comparing the rates of operations before and after the year 2013. And this is a recently published study coming from Harran University, that's a reference center in the Southeast region where the incidence of DDH is very high. The rate of newborn hip screening rise from 3.5% to 93%. And while the pelvic osteotomies constitute 77% of the all DDH operations in 2012, this rate was found to be 48% in 2019. And also the rate of close reduction rise from 20% to 46%, and the rate of open reduction rise from 3% to 6%. Also, the rate of failed pelvic treatment in the close reduction group significantly increased, and this showed the increased rate of abduction bracing in earlier ages. So in conclusion, the success of the nationwide newborn hip screening program is primarily due to the close collaboration between the Ministry of Health and the National Society of Children's Orthopedics. Also, the support of orthopedic surgeons, participation of other related specialties, as well as the increased awareness of the parents are the essential factors. So according to the 9 years of experience, we can say that although we have a considerable high number of live newborns per year, the number of screened babies increased year by year, and we now have an universal hip screening program that includes the screening of almost all live newborns. Year by year, the rate of abduction bracing increased, the number of minor operations increased, and the number of invasive operations significantly decreased. And I'm proud to say that many orthopedic residents can only see a couple of major DDH operations in children. So let's finish my talk with a famous saying of Professor Grab: let the others perform hip surgery, do ultrasonographic screening. Thank you.
So I will end these presentations with a recommendation: what is the best, a clinical, a selective, or a general ultrasound screening program? We all agree that the goals of all DDH screening strategies should be to early detect a baby with DDH in order to start with an early, appropriate treatment, to reduce the rate of late DDH, whatever the definition of late DDH may be, and therefore to reduce the surgical interventions related to DDH, which are significantly correlated to a bad prognosis of a baby hip with DDH. What are the problems of literature regarding screening programs? Literature is difficult to interpret because of different methods which are used and often combined in the papers. Most of the studies are substantially underpowered to detect significant differences, and maybe more than 100,000 infants are likely to be enrolled, are needed to be enrolled to report significant differences. The definition of late DDH is inconsistent. Is this a neglected hip older than 12 weeks, older than 6 months? This definition is inconsistently used throughout literature, and the screening strategies highly depend on the healthcare system and the politics in the different countries. Opponents of general ultrasound screening programs hold that a general screening program always leads to overdiagnosis and overtreatment, does not influence the rate of late DDH compared to selective or clinical screening programs, and does not reduce the rate of surgical interventions. And as you may know, Austria has a general ultrasound screening program since Professor Graf is from Austria. And the ultrasound screening program as a national surveillance program was introduced in Austria in 1992 with the ultrasound technique according to Graf. We have a so-called mother-child passport, which is directly linked to money mothers get from the country if they bring their child within the first week and in the 6th and 8th week after birth to hip sonography. Those two screening time points were related according to the maturation curve we've already seen. In order to evaluate our ultrasound screening program, we did a statistical analysis of all infant hip data concerning DDH in Austria from 1992 to 2008. And we tried to answer the following questions. Does the general hip ultrasound screening program, as we use it in Austria, lead to overdiagnosis and overtreatment? And with our analysis, we found out that the rate of conservative treatment in Austria decreased since the 80s, when in Austria, pediatricians and orthopedic surgeons started to use hip sonography, and significantly decreased from the year the ultrasound screening program started in Austria, and still is decreasing. The second question was, could the number of first hospital admissions be reduced? And we found out that from the early 90s to 2008, there was a reduction of 62% of inpatient first admissions per 1,000 live births because of DDH to the hospital. The third question to answer was, could the number of first surgical procedures be reduced? And we tried to differentiate between open reductions and more invasive pelvic osteotomies, which we perform after walking age, and we found out that there was a significant reduction of 30% between 1992 and 2008. The open reduction rate in 2008 was very low, with 0.16 per 1,000 below 4 years, but immigrants from unscreened countries were included in these statistics. Further or more recent studies from Austria showed that the open reduction rate is still decreasing. And with this paper, we proved that at the moment we have an open reduction rate of almost zero, with a rate of 0.07% and the treatment rate of 1% in Austria. The Austrian results are supported by national studies from Germany, where an open reduction rate of 0.26 per 1,000 was published, and from UK with the paper comparing three different screening groups, one with the clinical, one with the selective screening program, and one with the general screening program. And more than 30,000 babies included in the group with the general screening program showed an open reduction rate of 0.06 per 1,000 live births. So where are we going? Which should we recommend, a clinical, selective, or general hip ultrasound screening program? We all agree that a dislocated or an unstable hip at birth can be diagnosed easily by clinical examination. But hip abnormalities without instability can only be detected by imaging techniques such as hip sonography. And we found a strong correlation between sonographic unstable hips and the rate of clinical stability. And if you look at the 2C unstable hips according to graph, the rate of clinical stable hips would be 75%. So you would miss 25% of unstable hips with clinical examination only. What are the problems of selective screening programs? That there is no consensus about the amounts of risk factors which should be taken into consideration when performing a selective screening strategy or program in a country. The only agreed risk factors, which are more or less evidence, are a positive family history, breech position, and clinical instability. But if you only take these three risk factors into consideration while doing a selective screening program, you would only screen 12 to 16% of all newborns, because only those would be defined as at risk. If you look through literature of all those reported outcomes of selective screening programs, more than 15% of the population was screened by ultrasound. So different selective screening programs take different amounts of risk factors into consideration. And if you take all those risk factors and screen a baby with the risk factors, maybe you will have an almost general hip ultrasound screening program in your country. So how to choose now? What should we choose? Which factor is the one to prove to be the best? So if we all agree that severe DDH is late diagnosed and needs open reduction, and that the surgery influences prognosis badly, then the rate of open reduction per 1,000 births per year for each country with the selective or general hip ultrasound screening program is a reliable outcome measurement to compare different strategies. And literature therefore gives us a clear answer with decreasing incidences of open reduction rates in general screening program countries. So as a take-home message, general ultrasound screening programs do not lead to overdiagnosis and overtreatment, with at the moment reported treatment rates of less than 1%, compared to rates of selectively screened study populations of 2%. It does reduce the rates of late DDH and open reduction to an almost zero level, with incidences of 0.07 in Austria to 0.16 per 1,000 live births. So in conclusion, in my opinion, any other than general ultrasound screening program is a compromise. Thank you.
Okay, it's time for discussion, and can we ask all the panelists to open their webcams and microphones? Okay, we have a couple of questions. The first question is triple nappy therapy and repeat scan at 12 weeks. Anybody wants to comment on it? Probably for normal hips or scanning. The question is not so clear. Mauricio, would you like to comment?
Yeah, we performed a study about the double diapering, and there's clearly the answer. There is no effectiveness of putting some diapers on a baby. The diapers do not influence the position of the hip, particularly the abduction and deflection. I don't have results about triple diapering.
Any other comments? Bettina, Blages, Renata?
So
Yeah,
about, okay, go Renata.
I agree. The nappy therapy is not evidence-based, and it's not an option not to look into the baby hip and to do double or triple nappy therapy.
And gives the parents a false confidence as well.
It's an alibi.
Okay.
Exactly, and to keep the hip in the good position, we need at least 90 degrees of flexion and 6 degrees of abduction. I'm not aware about any standard diaper to keep this position, so no, and no.
I totally agree with that. Well, it's nice, or it might in type 2A plus hips, which need a control, that the parents are reminded there is something which has to be controlled. It's not very, very normal. So it reminds them that they have to go to a control examination, and therefore it might help.
We have another question that can be answered by any of the panelists.
Maybe I can make a comment on this question, Hakan. So the question was, can one of the speakers please comment on what the role of femoral head coverage percentage in conjunction with alpha angle graph scans is? So if you've learned the technique accurately, then you will know that the alpha angle does not represent the femoral head coverage. So it's all about the hyaline and the cartilaginous acetabular structures in the baby hip, what Graf tried to teach us. So you can only try to define femoral head coverage with the description. If you look on the bony roof and see if it's good or deficient, then you may say good if it's more than 50% covering, deficient if it's 50-50, and poor if it's less than 50%. But the alpha angle does not correlate with the femoral head coverage.
And it is certain that graph technique, graph method does not include any description like femoral head coverage.
Yeah, true.
Mauricio.
Yeah, another point is that femoral head coverage depends on the position of the baby and of the femur. Instead, alpha angle doesn't.
Yeah. So Hakan, there's a question to you. Are there good and accurate models available for practicing infant ultrasound technique?
I'm going to talk about the graph technique. The only and the best way to be trained about the graph method is the courses that is given by the certified trainers. There is no models or anything else. And in our country, we make this by training the trainers, then they perform ultrasonography courses, hands-on ultrasonography courses. There is no way, no other way to train the practitioners about the graft method.
Yeah.
It is not a bedside training. It should be trained in ultrasonography courses.
Mm-hmm. Bettina, I have a question to you. You did a lot of literature review on the recent literature regarding selective screening programs and abnormalities in the infant baby hip, and that a lot of unstable hips can be only followed by wait and see tactic. Did you find anything regarding risk factors in those papers with proposing selective screening programs?
Well, you already mentioned it's mainly breech position, family history, and positive family history. And for the development of the 2A hips, well, there are some papers mentioning some risk factors, but others, for example, sex and breech position, but others didn't find that, couldn't correlate that with the positive development of the 2A hips. And so actually, I thought it was very interesting, the alpha angle, the gamma angle, sorry, the gamma angle, but I never saw another publication re-evaluating this factor, but I thought it was very interesting.
Yeah, the most interesting point.
Everybody of you use the gamma angle?
No. But the most interesting point was that countries with selective screening programs have a big amount of risk factors they take into consideration to screen a baby. So if you do that, you almost have a general screening program, because then you have a high percentage of screened population.
Mauricio, we have a question to you. At what age the screening is done? You already mentioned it, but in your daily practice, at what age you make the screening, and who does the ultrasonographic examination?
The ultrasound screening should be performed before discharge of the babies from the neonatology. This is the sure strategy for have a lot of the high percentage of screened baby. Another strategy is to say if we have some problems with the colleagues, with the examiners, to suggest until the 6 weeks of life, but not later. In Italy, there is no consensus about a universal screening, no consensus.
Mm.
But otherwise, I see my position a lot of late diagnosis, because so this is my fight against the late diagnosis. The key is the early diagnosis of DDH, not ultrasound or clinical examination. The early diagnosis is the key point. And I'm sorry, you can do that only performing ultrasound. Now, I don't know, in 10 years, in 20 years, what happened, but now I think this is the answer.
I have a question to Blažej. There's a question: do you recommend any type of exercise or physiotherapy after conservative treatment of DDH?
So we know that the limited of abduction, it's a risk factor. So maybe recommendation of physical treatment is not the best idea, but to improve the abduction, yes, we should have a good abduction, and especially to allow kids to move normally, not to restrict hip motion at this time. So I will say the hip motion is the most important.
Okay.
Renata, there is a question to you. Why UpToDate yet doesn't recommend the universal ultrasonographic screening?
It's a pity. This is really bad. Yeah, we have. There was a question today by email coming up over our EPOS secretary. There is a new paper with the meta-analysis from Finland published this month in August, showing that there's no difference, no significant difference between selectively screened population and generally screened population. But if you look through the literature which was taken for the meta-analysis, there are a lot of bias which maybe you only can define if you really know by heart what is all around the hip sonography. The first thing is that, again, selectively screened population take a lot of risk factors into consideration which are not evidence-based. So at the end, every baby was screened. So we compare general screening population with general screened population, but they call it selectively screened. And the next thing is that there are lots of papers which were published in the early 90s when the screening technique started and when the countries had their learning curve and the pitfalls and the errors. And for those who published in the early 90s with a selectively screened population, they had an almost zero treatment rate because they maybe didn't know how to use this technique correctly. So I think, in my opinion, we should only take recent papers into consideration who have a long learning curve with this technique and definite clear risk factors for selectively screened population. So, Hakan, I don't know, what's your opinion about that?
I have no other opinion other than yours. Completely agree with you.
I would like to mention also that we have something which we call silent dysplasia, which is about 6 to 8%. So even with good clinical examination, we can miss these kids, which will be the pity with the knowledge that we have now.
Yeah. So there was a question, when is the next graphs instructional course in Europe? So I think this needs to be an English course, not an Austrian-German course or a Turkish course. So any one of you planning an English instructional course?
I think we have to offer this to our educational committee.
Yeah, great. Yeah, we should that. Yeah. So I think there are two more questions about treatment. Post-public harness treatment, would you wean out or just stop the treatment? Bettina, how do you do it in Germany?
Usually, well, I treat until an alpha angle of 65 degrees. And then usually, if I'm very happy and convinced that the result is fine, then I stop immediately, no weaning. Sometimes in cases when the bony rim is a little bit roundy, a little bit, then I say to them, just wear brace during nighttime.
Okay. And which harness or abduction splint would you recommend for countries who do not have public harness available?
Actually, I never used the public harness.
Okay.
I always use the Tübingen splint, which is very easily to handle, and parents are very happy with it, and yes, can cope with it very good, very nicely, and it's well accepted.
There is a comment from the audience. In reality, does femoral health coverage more than 50% correlate with better prognosis for achieving hip maturity again this finding? Any one of you would like to comment?
First of all, I would like to say that the reliability of the femoral head coverage has a kappa value interclass correlation coefficient of 0.0.2 in the meta-analysis. So it tells us this is not a good, reliable parameter. And actually, I do not know whether it's correlating with the alpha angle because I never use it. I'm only using the graph method and I never use the femoral head coverage index.
Mm-hmm.
There are some paper which compare the different techniques, Teresian and Morin and Suzuki and the French one, and the conclusion was the best parameter for DDH evaluation is the alpha angle, definitively.
Mm-hmm.
So there is another interesting question. When do panel members agree to stop ultrasound screening and switch over to radiographs? So what is your uppermost age limit for ultrasound in your daily practice? To all panel members. Yes?
12 months.
Yeah.
12 months, Mauricio.
Yes. Yes.
Bettina?
So to answer this accurately, I will agree with Maurizio, it's around 12 months, but to answer it accurately according to graph, from the point the ossific nucleus is covering the lower limb of the bony roof, you're not able to measure the alpha angle and then you're not able to do measurements. This might be in a 7 months old with a big ossific nucleus or in a 12 months old, but it's around 1 year, yeah.
And this does not mean that you have to perform at 6 months, for example, at the end of treatment X-ray of the pelvis. But if you have done if you can see the nuclei, you can still look at the nuclei appearance later by ultrasound, not by X-ray.
Mm-hmm.
In normal developed hips after treatment.
Why do you have to perform an X-ray at the end of treatment? I never do it. We do the first.
It's a legal problem. It's only a legal problem.
But the ultrasound gives you a much better picture of the hip.
Yeah,
because
I'd agree with you.
The cartilage.
But if you don't have a documentation of the old method like X-ray of the pelvis and you have some problem, there is another problem. So we used to perform an X-ray at the end of treatment, always. But we can discuss in the future about this strategy.
Actually,
I think I can.
At least in our hospital, the X-rays are very often of a very low quality because they are not symmetric, and actually you wouldn't be allowed to analyze them. Is it better in your hospital? Or what is your experience with that?
No, I don't think. I think almost 30% of the X-ray of the pelvis over the world are not good X-ray in the technique. There is some errors in the position of the babies. That's also true.
And Bettina, do you do follow-ups after walking age of type 3 and 4 treatment with X-ray?
Follow-up for any children who had treatment. So we perform the first X-ray at the age of 18 to 20 months, and then do a second one at the age of about 3 to 4 years. And we follow them up to the age of skeletal maturity.
Mm-hmm.
I do the follow-up, the X-ray after the treatment at 2 years old. According to tennis, we should have a cellular index 24 degrees and 24 months. So I think that this is the best like rule to see how is the acetabulum development. So I usually wait till 2 years of age for the X-ray.
Baja, there's maybe a question for you because you talked about immature hips or early onset. There was a question, if there's a premature baby born in the 32nd week and there are risk factors, do you do the ultrasound directly or do you wait until the calculated date of birth? And when would you start with treatment?
So this question is a little bit difficult to answer, but based on my experience, I'm orthopedic consultant in the newborn department, and every kid at risk born before the 36 weeks of age I'm called to make an ultrasound. And based on that, except some really exceptional teratogenic dislocation of the hip joint, I never saw any really dysplastic, severely dysplastic hip joint in 32 weeks. So with the normal clinical examination, I may say that we can wait a little bit, but and do the ultrasound only in bad clinical examination, limited abduction or apparent shortening of the lower extremity or something like this.
Mm-hmm.
Renata, there is a question, but the answer is certain. Are the baby cradle and ultrasonography probe tower necessary for proper hip ultrasonography by the graft method?
Of course, if you would like to minimize tilting errors, you should use that.
The so-called freehand ultrasound is not good. And there are some papers about that. And I think we should also look at the quality of the images, of the published images, because we are talking about results of sometimes from paper with no qualities of images.
I agree. When we look at the literature concerning the late diagnosed cases, in some papers, I can see some insufficient images about the graft ultrasonography. These hips are not late diagnosed hips. These are initially missed cases. Even in the very well-known journals, we can see such images.
And you know, when you do tilting error, it's really easy to make from some 2C hip a type 2A hip just because of the tilting problem. So all this holding device, it's really helpful, and it keeps our kids safe, our patients safe.
Okay, we have another interesting and long question. If current hip ultrasound techniques all have low and declining reliability despite intense educational efforts, should other ultrasound systems not be pursued rather than increasing the teaching of these systems? For example, 3D ultrasonography and so on.
So may I answer a little bit this question? Because I was lucky to work with Professor Harkin in the United States and make some study, and it was published also. And I was lucky to work with Ali Fuat Karatas, which is one of your Turkish friends, about the 3D hip ultrasound. And unfortunately, due to the morphology of the hip joint and very low liquid, it's so difficult to make a reliable hip ultrasound in the 3D view. So I think that maybe we need a better understanding of the hip motion, and then some of the dynamic screening techniques may be helpful, but it's only a help from other technique. But because graph prove it that there is the best way for screening, very repeatable and reliable technique. So I think that others may be helpful for understanding, not for screening or treatment.
I don't think that graph technique is not reliable. If you follow the strict rules of the graph technique, it is highly reliable and repeatable.
Yes, of course, it's what I was trying to say.
But it's the problem that a lot of people do not use the checklist and everything like that. And it's a problem with the quality.
Of course, completely agree.
It's what Renata mentioned. It's just the proper line drawing, checklist 1, checklist 2. We need to be very strict on that. Of course, with time, we get a little bit more of experience in that, but we never should forget about being in the proper position without any tilting and draw the line in an accurate way.
You have to be very strict, like the pilot's checklist.
In Germany, we do have a quality management control system. So colleagues who do not fulfill the criteria for the quality, they lose their license or do have to do another course or anything like that. So that really improves the quality and reliability. So yeah, quite happy with that.
Yeah.
But it's not perfect yet.
Otherwise, the social security system is not covering the costs.
Oh, they lose the license for the ultrasound examination.
Okay.
Hakan, there's a question about predicting growth. Is an attempt to predict growth of a hip an example of inductive logic and not scientific? Is it not better to observe periodically to maturity? So I'm not really sure if I understood the question, but if this
Probably
was
about type 2A hips.
yeah, if this was about type 2 apes, then yeah, maybe it's inductive logic and not totally scientific, but at the end, we have this maturation curve, which is having a plateau early. And then if we find out that at the time of plateau, the hip is not mature, the hip is unstable, becoming unstable, or is dysplastic, we have lost a lot of time. So this is emotionally bad for the parents and still is also not scientific because we don't know what the natural history of a DDH hip is. So we always need to be faster with all the knowledge we have nowadays.
Exactly.
How do you okay, you can. How do you perform ultrasound in patients that are under treatment?
Yeah.
Especially these unstable ones. Do you removing your braces or not while performing ultrasound to all panelists?
I remove it.
Me too.
So I start with the Harkey technique when the public harness is put on, and then I remove it and check with the graph technique to have a better measurement and something which I can repeat the measurement.
A double technique.
Does anyone use the rhino abduction brace?
Which one?
Is this the Rosen splint? The rhino abduction brace? So I just need to Google it because I didn't know what the rhino abduction brace is. And this is this thermoplastic splint. I think it's like the Rosen splint. You make it hot and then you can adopt it to the baby, but I have no experience.
No, me too.
Okay.
No idea.
So maybe as the Scandinavian people, they have a lot of experience with the Rosen splint. Maybe they can next EPOS webinar talk about the rhino brace. What percentage of adult total hip replacements are due to hip dysplasia?
In my country, it is 1/3.
In Italy, we have a register, all country, we have a register of DDH prosthesis, and it changed between 30% and 10% in the years.
Yeah.
All patients. But the problem is that the DDH osteoarthritis are in younger patients, 40, 45. And so they have a long follow-up, and not so sure and safe follow-up because of the young age.
I think that we cannot enter to this discussion what is the femoral subpolar index. It is due to the hip dysplasia or something other risk factor. But also the problems on the reporting. How do they report? I saw in my country many people reporting a type 2A hips like hip dysplasia and coding like ICD-10 Q65, which may really interfere with the later statistic.
Some osteotomy questions we have, but it is out of the scope of this webinar. So
A lot of questions, Hakan.
a lot of questions I'm trying to follow. How long does it takes you to make one exam, one hip? It's a technical question. It depends on your experience.
And on the behavior of the baby.
So if everything runs well and the baby is calm, it's 10 seconds.
Yes, I agree.
Yes, agree.
But it is always necessary to have at least 2 images.
Yeah, true.
Correct images,
Yeah.
at least. So it may extend up to 20 seconds in order to have another image.
It's not finished computer.
Yeah.
In some countries, pediatric clinics do not have ultrasonography specialists, and for some reasons they can't afford it. How to screen the babies at these clinics? It's about a question. If we do not have an ultrasound, what should we do to screen the babies?
I think the ultrasound machine we can find in every department, in surgery department, in radiology, or somewhere else. So it's just the question of organization. If we are in the hospital or big outpatient clinic, the problem is in some places when there is no medical services. So how to bring people to the clinic where we have ultrasound? This is the question of the organization of the healthcare. And in these places, I think the maternity department, when we can do the ultrasound at the discharge of the newborn, it's a good idea to do the screening.
The problem is more having trained examiners than ultrasound machine. You can buy an ultrasound machine today for 3,000 euro or less, with acceptable quality of the transducer.
Yes, exactly. Trained staff. Yes.
So for training staff, it go for the course.
Yeah.
And the last, I think, the question, what is the uppermost age limit for public harness usage in your hands?
The problem is the diagnosis of type 4 hips. There is a paper that say not good, the public harness in type 4 hips. Or you publish about that, Hakan? I don't know.
Yes, yes.
2013, some.
The public harness does not work, especially over the age of 4 months and in graph 4 hips, in my experience.
In late diagnosis, I'm sure it doesn't work.
Okay, Renata, I think it's time to close.
Should we close the webinar? We have some questions, but we will not be able to answer every question because it's 7:30 and we're overdue. Thank you, Hakan, Blage, Bettina, and Maurizio for your contribution to this DDH screening webinar. Thank you to more than 600 registrants for this EPOS webinar, which is really huge and a record, as I heard. I would like to mention to you colleagues the upcoming EPOS advanced course on pediatric hand and upper extremity surgery in November in Speising. Please do not miss to register. The last course in 2019 was hugely successful, and there will be a big faculty, so check for further information for the EPOS advanced courses on the web page. And with these words, I would like to say you stay healthy, all the best, and see you at the next annual meeting in Krakow, in Poland. Goodbye.
Thank you. Bye-bye.
Yeah.
Bye.